We'll move now to our second speaker of today, so Marta Iscla. So Marta is a nurse by training, and she's worked with MSF at field and headquarter level since 1996. She has a degree in public health and tropical medicine in developing countries, as well as a master's degree in simulation for healthcare, and is a member of the European Society of Simulation in Medicine. She's currently the MSF Field Simulation TIC Program Manager, aiming to operationalise the use of simulation and use simulation as part of the quality improvement process. Her presentation is entitled MSF Field Simulation, Incorporating Simulation into the PLANDO-STUDY-ACT cycle for an integrative improvement of the OPD triage system in PULKA, Nigeria. Thank you very much, Marta.
Thank you, Johanna, for this introduction, and good morning, everyone. It's a pleasure to be here today to present this experience about incorporating simulation into the PLANDO-STUDY-ACT cycle for this integrated improvement of the OPD triage system at PULKA level, Nigeria. Simulation in healthcare education as a teaching tool for increased competence is well recognized, but its role when it's used for quality improvement is less known. In fact, simulation is a versatile methodology that, when it's used for quality improvement, it's very powerful. When we were in PULKA, the team raised that there was a problem of late detection of critical ill pediatrics and adult patients presented to hospital level OPD triage. It means the rare cases were frequently missed at triage level and were identified at consultation level. From MSF Field Simulation, we propose to use simulation to understand, analyze, and address this problem by incorporating it into the PLANDO-STUDY-ACT cycle. The PDSA is part of the universal and recognized model for improvement, and it provides a foundation for an attitude of continuous improvement. What we did is to, in the integrate simulation in the different phases, we use simulation to analyze and plan design improvements. At the level of do, we use simulation to embed best practices. And at the level of a study, we use simulation and structured debriefing to test and study the changes. In fact, what we did is combine quality improvement processes and simulation. In the plan phase, we use tabletop simulation, which is a low stress simulation exercise that allows teams to analyze, design, and plan improvements and complete the cause-effect diagram. And the team itself were identifying the areas of improvement. They design and define the solutions, and they make these improvement plans. At the level of 2, the improvement plans were implemented, and including 6 educational simulations on the triage tool chosen, which was the interagency integrated triage tool. At the level of the study, tally sheets were implemented, and also we observed how the team were implemented the new triage tool after the simulation, the educational simulation, and also we ran some structured debriefing at the workplace during the implementation of the new triage processes to make the adaptations needed. At the end, the triage process was established, and after this positive experience, the team itself were interested in using simulation for the preparation of the malaria peak period, because they were worried because the number of patients was 3 more times, and also because even the identification of critical cases were also even more difficult. Then we repeated the processes. We repeat another tabletop simulation exercise, and also at the level of the study, we did a walkthrough simulation, including the community, to be sure that the perception of the community were considered in the design of these new triage processes. At the end, simulations implemented the problem analysis, facilitating the causes identification and the definition of the improvement plans at the level of the space design, the team composition, the task distribution, the design of the processes, and also the staff competence. And although we didn't have baseline data, the post-intervention data showed a high functional triage system, because from 4,331 patients triaged at OPD for over 30 days, were identified 59 red cases, and from these 59 red cases, 96.6% were identified at triage level, which was the purpose of that intervention. And from that 25 25 points observation checklist, we observed that the staff completed between 96–100% correctly. And the most important is that the team itself were decided, were chosen simulation to design and analyze the triage organization for the oncoming malaria peak. The conclusion is that simulation is a powerful tool that can be used to drive quality improvement processes. In this situation, the simulation helped to redesign, to test, to adapt a new triage system. Incorporate simulation in the PDS a cycle is feasible. It allows teams to identify and implement improvements and test and study solutions. And it's very motivational because it involves the staff on designing these improvement plans. And what is important, it can include the user's perspective on the design of these quality improvement processes. Thank you.
Thank you, Marta. I don't need much convincing myself, and I'm fascinated by the intersection of training initiatives and especially simulation with the quality improvement process. And I think anyone who's worked in simulation will understand that performance gaps are rarely just an issue of pure knowledge gaps. So exploring systems-based factors is really important. And I think the learning by doing aspect allows the team to discover systems level problems. Just going to the questions. Trying to see, there were some questions there. I don't have it's not popping up for me. While I'm waiting to do that, I just wondered myself, what is the reactions of your staff to this? How did they react to this whole process?
No, the reaction was positive because it's themselves who decide to repeat the processes for the upcoming malaria peak. They were so positive results, and they were so engaged on quality improvement process because they were part of it, that themselves, we want to do the same for the upcoming malaria peak, which was great.
Yeah, great. And so I've got some questions come through. The first one is, how did you include the community in the design and testing of the triage process?
What we did after the tabletop simulation exercise, that it was a work done with different people involved in the triage system and also in the management department and the managers. During the walkthrough simulation, which is kind of a full-scale simulation, and we invite the community to participate in this full-scale simulation in order to get their perspective, how they were seeing this new triage system for the upcoming malaria peak, because normally they are the users during the malaria peak, and then there will be a new processes, a new flow, and we wanted to get their perspective, and they were really, the feedbacks were very positive from their side. They see that, because also the idea was to reduce the waiting times for them.
Yeah. Okay, there's a whole range of other questions that have just come through, and I think we won't have time to ask them all, but I'd encourage you to go and speak to Marta during the break and ask all your questions at that time. Thank you again for joining us this morning, Marta.
Thank you.